Thank you for the introduction and good morning. It gives me great pleasure to be able to speak with you virtually in Chengdu at the annual meeting of Sichuan Medical Doctor Association. My talk is on the management of hypertension in commonly treated populations for nephrology. So this presentation includes highlights from the National Kidney Foundation Spring Clinical Meeting, which was also virtual earlier this year. So I wish to thank our chair, Professor Li Wang, for the invitation, and InMed and the organizers for supporting me to do this and for you to have this virtual meeting. I think it's wonderful. And of course, thank you very much to our fantastic translator, Professor Hong, for helping me. So as a nephrologist, we see many different patients for the management of hypertension and other nephrology-related issues. So I'm going to focus on special considerations of management in hypertension in populations we commonly see. So this is the typical elderly patient and diabetic patients with chronic kidney disease. And this is in distinction to more rare circumstances that we may also be involved in, such as the problem with resistant hypertension. I won't talk about this in this lecture, but it is something that we could talk about. And if I have time, we may touch upon the management of hypertension in patients with on dialysis. So the elderly population is the most rapidly growing population, and now they are living longer. So for example, patients who are 80 years old now have an average life expectancy of 9 years. So this is 50% more than in the 1970s. The prevalence of arterial hypertension, particularly systolic hypertension, is constantly rising worldwide. And this is mainly the clinical expression of arterial stiffness as a result of the aging population. The prevalence is very hard to know what the true prevalence is because of the differences in definition of hypertension in the elderly, which varies by country and by societies. Hypertension, as you all know, is very common in patients with chronic kidney disease, and the prevalence ranges anywhere between 60 to 90%, depending on the stage of chronic kidney disease and its cause. So I am now 79 years old, and my blood pressure is 140/88. And I'm coming to you as my doctor. Should my blood pressure be A, lower, A, yes, B, no, C, it depends, or D, don't see a nephrologist, you should see a geriatrician. Maybe we have evidence from the literature that may be able to help us. And this was a study that was published earlier in JAMA in 2016. It's the intensive versus standard blood pressure control and cardiovascular disease outcomes in adults aged greater than 75 years old. It's a randomized controlled trial, and the short form of it is called SPRINT Senior. The design of this study is a randomized controlled trial. As you can see, there was 36 participants. They were randomized to a standardized blood pressure control target with a systolic blood pressure of less than 140 and an intensive arm with a systolic blood pressure of less than 120. You can see that it was evenly distributed with 1317 and 1319 patients. Importantly, for the inclusion criteria, patients were greater than 75 years old, and an average of almost 80-year-old patients participated with a follow-up of 2,500 participants. The median follow-up was 3.14 years, and the primary outcome was a cardiovascular composite outcome of myocardial infarction, non-fatal stroke, non-fatal acute decompensated heart failure, and death from cardiovascular causes. A secondary outcome was all-cause mortality. The major exclusion criteria were patients with stroke, patients with diabetes, and patients with congestive heart failure. Also important were patients who are nursing home patients, patients with dementia, hypotensive, limited life expectancy, weight loss, problems with adherence, and for a nephrologist, very importantly, patients with proteinuria greater than 1 gram, eGFR less than 20 by the MDRD equation, and polycystic kidney disease. And I really want to highlight that it was quite limited because patients had to be independent, community dwelling with good cognitive function. So what are the outcomes? It was very impressive. The main cardiovascular outcomes was statistically significant with the number needed to treat of 27 patients over 3.14 years to prevent a main outcome. We only needed 41 patients to prevent a death, and combined, the primary and all-cause mortality outcomes was statistically significant, with a number needed to treat of approximately 41. So I'm coming back to you now, and because of the results of the study, I realized, yes, my blood pressure should be lowered. But what should the blood pressure goal be? Should it be A, intensively controlled, like sprint to less than 120, following the AHA guidelines of 130 over 80, or just leave me alone right now, I don't want to think about it, or D, it depends. So you can see from the blood pressure targets in the elderly, there is quite a wide range, but the different societies giving different values, from KDIGO saying individualized to values as low as 130 and as high as 150. Sometimes it depends on your comorbidities, sometimes it depends on the age. So there is a range of recommendations. So right now, the recommendations that I can share with you is these following recommendations. This one has a class of recommendation of 1A, which is moderate or reasonable. And it says that treatment of hypertension with a systolic blood pressure goal of less than 130 is recommended for non-institutionalized ambulatory community dwelling adults greater than 65 years old who have a blood pressure target of greater than 130. The second set of recommendations are for older patients with high blood pressure with a burden of comorbidity and limited life expectancy, where you would use clinical judgment, patient preference, and team-based approach. And we know that the evidence for this is a lot less strong based on a lot of the exclusion criteria that we saw in the SPRINT study. So this study is a sub-analysis of a study called PARTEDGE, the predictive values of blood pressure and arterial stiffness in institutionalized, very aged population study. And this highlights why clinical judgment is so important. So this was a longitudinal study of elderly patients living in nursing homes. There was 1,127 men and women who were greater than 80 years old living in nursing homes in France and Italy, and they were followed for 2 years. So what they looked at was blood pressure management with a blood pressure target of less than 130 compared to patients who had blood pressures of greater than 130. And then they looked at the number of blood pressure medications, less than 2 or greater than or more than 2, and then they followed them for mortality. And you can see here in the Kaplan-Meier curve that those patients who had low blood pressure with multiple blood pressure medications had poorer survival. So in fact, patients who had low blood pressure, who were receiving multiple blood pressure medications, had an 81% excess risk of mortality compared to all of the other participants. So to answer that question before, I think the answer is it really depends. In this study, the very old, frail, institutionalized patients with low blood pressure and multiple blood pressure medications had a twofold increased risk for mortality. So are those results from that PARTEDGE study that we just talked about also reflected in SPRINT Senior? So when we look at it, we can look at it according to the frailty status of the patients. And overall, when you looked at SPRINT Senior according to frailty, there was more events in the more frail patients in both groups. But within each frailty stratum, it seemed like there was benefit for intensive lowering of blood pressure. So you can see here, there was separation in the less fit group for intensive blood pressure lowering. No, not so much difference in the patients who were very fit. And then in those patients who were very frail, there did not seem to be a significant difference. So how frail is frail? So how relevant are those SPRINT Senior results to community dwelling seniors? So this slide demonstrates that in these studies of hypertension here, that the majority of patients were actually not considered very frail. So the score that they use is frailty index. Anything above 0.21 is very frail, as indicated by this blue line. And then anything indicated above 0.45 is indicated to mean very, like the most frail. And if you see the patients that were involved in these studies, there were no patients that were most frail, and only about 10% of patients who were very frail in these studies. So in other words, these hypertension studies had pretty healthy, independent patients who participated and not the very frail. So you need to keep the patient population in mind when you're using the SPRINT Senior results to your population. in the discussion of the Sprint Senior publication, they said that 64% of Americans would actually fit into that criteria. And it may be different for you in China or me in Canada. But what about serious adverse events? As nephrologists, we are concerned about kidney injury. So acute kidney injury, decreased GFR, and need for kidney replacement therapy. And as you can see here, it does not seem like there's any statistically significant difference for these bad kidney outcomes in patients with baseline chronic kidney disease. However, if you look at patients who did not have chronic kidney disease at baseline, there was a significant hazard for reduction in eGFR by 30%, need for dialysis and transplantation. So the findings of this increased risk of adverse kidney events that we see in Sprint Senior without chronic kidney disease as a baseline is also reflected in all of these other studies where you can see that there was an increased risk that favored the standard control compared to the intensive blood pressure control. So we must be very careful with regards to acute kidney injury. So are there any other benefits to lowering blood pressure that might be relevant to the elderly population? For example, would reducing blood pressure be protective to the brain to prevent cognitive decline or dementia? So this meta-analysis of 4 major studies suggests that this might be the case, as you can see that there is a reduction in relative risk for dementia outcomes with lowering blood pressure. In this study called the Sprint Mind, which has included all of the Sprint studies, not just the elderly, they looked at lowering systolic blood pressure to less than 120, and they found that it did not reduce the risk of probable dementia. But if you looked at the secondary outcomes, it did appear to have some benefit in improving mild cognitive impairment and a combination of mild cognitive impairment or probable dementia, as you can see by the hazard ratios here. So I think that the study was not followed long enough and was not powered to definitively answer the question of whether intensive blood pressure lowering impacted cognitive function or really prevented dementia. So in terms of what medications would we use to lower blood pressure in the elderly patients, I think we really need to take a very good look at what the relevant comorbid conditions the patients might have and the associated risks with these medications. So for example, if you had a patient who had isolated systolic blood pressure, then a long-acting thiazide is a really great first choice. But you need to determine, does this patient have depression, and are they using an SSRI where the risk of hyponatremia may be great? And of course, as nephrologists, we treat patients with chronic kidney disease with hypertension, so we need to look at other risk factors for AKI if we use an ACE or an ARB as a primary medical therapy. So next we will talk about patients who have chronic kidney disease, because this is our bread and butter. So we spoke about this before. This was the Sprint results in the CKD cohort. And this was a cohort of 2,646 patients. The average age of these patients was 72 years old. 60% were men. The eGFR was average 48 or CKD stage 2. And the bottom line of this study is that the lower blood pressure goal in the CKD subgroup actually had a beneficial effect at reducing cardiovascular related events and death. So I'll just go over some of the results really quickly. So you can see that those patients who were randomized to the intensive group seem to have a trend towards improving the cardiovascular composite outcome. So it was very, very close, but didn't reach statistical significance. As you can see, the hazard ratio passed 1. However, it was statistically significant if you look at all-cause mortality. So one of the main outcomes was the kidney outcome, and the main kidney outcome was a decrease in eGFR of 50%. So you can see overall in CKD cohort that there was no difference between the groups with this outcome. However, the intensive blood pressure group did have a statistically significant less than a 30% reduction in eGFR, and it's not shown in this slide. So to summarize the findings of Sprint in CKD patients, it seems that intensive blood pressure lowering in patients with CKD does have a positive impact on all-cause mortality, a trend towards a positive impact for cardiovascular outcomes. There was not a 50% reduction in eGFR, but there was a 30% reduction in GFR in those patients in the intensive group. So, however, this decline in the GFR was felt to be hemodynamically mediated, which may be temporary. So we have to look at that poor outcome compared to all of the beneficial outcomes of lowering blood pressure in this group. So I think it is safe to say that in the elderly and in the CKD population, intensive blood pressure control is beneficial. But we have to be really thoughtful and about how aggressively we treat, especially in the frail elderly population and in the CKD population who is at risk for acute kidney injury or kidney decline. So what medications would we use if we were to be able to treat these patients? As nephrologists, of course, we want to be able to do double duty. We also may want to use medications that will delay progression of CKD. And at the time of the SPRINT publications, these were the agents that showed benefit in delaying progression of chronic kidney disease, and these agents are ACE inhibitors and angiotensin receptor blockers. This is what I used to recommend for medical treatment, and this is based on guidelines and evidence. So since I visited you last year, you may remember this, but I will review it. So for the treatment of chronic kidney disease patients with hypertension, the blood pressure goal that I use is less than 130/80, except if they've had a previous stroke, where we would target a systolic blood pressure of less than 140, and that's based on evidence. With regards to patients with CKD stage 4 and 5, it's really important to remember that we have very limited data in patients with stage 4 chronic kidney disease, and we have no definitive randomized controlled trials at all in patients in stage 5 needing dialysis. So we really have very poor evidence to guide us in those two stages. So what we do not recommend is the simultaneous use of ACE inhibitors, ARBs, or renin inhibitors, because they could be potentially harmful. So what we use as first-line agents include thiazide diuretics, particularly the long-acting thiazide diuretics, calcium channel blockers, ACE inhibitors, or ARBs. Beta blockers are not considered first-line medications now for hypertension unless they have a specific indication, such as ischemic heart disease or heart failure. So to summarize, in terms of the stages of chronic kidney disease, if they're in stage 1 or 2 and have albuminuria, then the ACE inhibitor is reasonable to slow the rate of kidney disease progression, and ARB can be used if an ACE inhibitor is not tolerated. And then in stage 3 to 5, really, there's, again, it doesn't matter if they have albuminuria or not, ACE inhibitor is a reasonable choice to slow the rate of progression of kidney disease. And again, to use an ARB if ACE inhibitor is not tolerated. And just a quick note that the strength of evidence is considered to be moderate for ACE inhibitors, but weak for ARBs. To summarize, from all of the different societies, the ADA, AHA, ACP, and Hypertension Canada, the easiest one for me to remember is the AHA one, because it's just 130/80 to be a target blood pressure goal. So that is what I used to recommend, but now there is new evidence, and I'm going to now tell you what I'm going to recommend today. And that incorporates new data involving patients with diabetes. And it is a very important population that we see that overlaps chronic kidney disease and elderly patients, is this population with concurrent diabetes. Worldwide, there are now 463 million people with diabetes in 2019, and the predicted growth is up to 700 million by the year 2045. So diabetic kidney disease, as we know, occurs in 30% of patients with type 1 diabetes and 40% of patients with type 2 diabetes. And we all, as nephrologists, know that diabetes is the leading cause of chronic kidney disease around the world, and approximately half of them have diabetes when they go on to kidney replacement therapy. So this paper is an article that is in press, so it's not yet published, and it talks about a new class of agents called SGLT2 inhibitors and its impact on diabetic patients with regards to chronic kidney disease and cardiovascular disease. So these sodium glucose cotransporter 2 or SGL2 inhibitors, they lower blood glucose levels by preventing glucose and sodium reabsorption in the proximal tubule. And so in the United States, at least, there have been 4 approved agents, and I have a hard time saying them: canagliflozin, dapagliflozin, empagliflozin, and ertugliflozin. And there have been a number of very important studies of these agents that you will see will have more benefits than just simply lowering blood sugar. So these are the results of a study called the Credence trial, and it is actually the first study that used canagliflozin as the SGLT inhibitor in the treatment arm versus placebo to have a primary kidney outcome. But I'm not going to show you that outcome because I think our next speaker may be talking about this. But what I will show you is the primary outcomes that are related to the cardiovascular system. So that's cardiovascular death, non-fatal myocardial infarction, non-fatal stroke, and hospitalizations for heart failure. And it may be hard to see on this slide, but in all of those instances, canagliflozin was very beneficial and statistically significant in reducing those cardiovascular outcomes. So the benefits of this class of agents, these SGLT inhibitors on the kidney and cardiovascular outcome, is very consistent among the various trials looking at the different agents within this class. So you can see on this slide that there's benefit for end-stage kidney disease, and you can see all of the studies listed below. You can see the benefit for loss of kidney function, end-stage kidney disease, or death due to kidney disease. And then in the panel C, you can see the benefit for loss of kidney function, end-stage kidney disease, or death due to cardiovascular disease or kidney disease. So very, very strong and consistent throughout the different agents and amongst different studies. And so the impact is so great that already we see that recommendations are changing in patients with diabetes among all of these different societies: the European societies, the American Diabetes Association, KDIGO, and AHA. So this class is very exciting for patients with diabetes, but what about non-diabetes? We have this study called dapagliflozin in patients with chronic kidney disease that was just recently published in the New England Journal of Medicine. So I think this is very exciting. This study randomized patients who are adults with eGFRs between 25 to 75. They were already on an ACE inhibitor or an ARB, and they may or may not have diabetes. So they were randomized to dapagliflozin, I'll just call it DAPA, 10 milligrams, or placebo, and then they followed them for the primary outcome. And in this situation, the primary outcome was a kidney outcome, a composite of a sustained reduction in GFR by 50%, end-stage kidney disease, renal or cardiovascular death. And really importantly, you can see that the population studied, about a third of them actually did not have diabetes. And you can see the causes of end-stage of chronic kidney disease in the other bubble here. Very importantly, in terms of the chronic kidney disease outcome, you can see that the patients that were treated with the dapagliflozin had a 39% relative risk reduction for the primary endpoint. And you can see for the individual renal-specific outcomes, you can see that there was a 44% relative risk reduction in patients who were being treated with the dapagliflozin. And this is a summary of all of the key events by in a different method so that you can actually see the relevant outcomes by hazard ratio rather than a survival curve. And you can see that they were all statistically significant for the renal as well as the combined cardiovascular outcome. So how do these agents actually delay progression of chronic kidney disease? And there's a lot of different theories out there, and of course, we don't have time to talk about it. So when this paper is published, I would encourage you to read it, but there's a lot of research that needs to be done because these agents not only have an impact on glucose lowering, which seems to be the most minimal of the effects, with major effects on the heart as well as the kidney. So I would encourage you to read the article when it is published. So let's go back to hypertension. Can we fit the use of these SGLT2 inhibitors into our treatment algorithm for hypertension? And we see here there was a meta-analysis of 43 studies, and the SGLT2 inhibitors had a modest reduction in blood pressure. But when we actually look at blood pressure effect over 24 hours, it seems to be more impressive with an average reduction of 3.8 by 1.8 millimeters mercury. So with all of this new data, this is my own personal approach to managing hypertension in chronic kidney disease now. So I still use the same target of less than 130 over 80. Of course, we have lifestyle modification, and that's another talk on its own, so I won't talk about it here, but obviously salt reduction is very important. My first-line agents are still a diuretic, a long-acting thiazide. I still use an ACE inhibitor or potentially an ARB if they're not tolerating it. And then I now consider an SGLT2 inhibitor and calcium channel blockers. For more patients with resistant hypertension or more difficult to control, my second line would be adding an MRA, mineralocorticoid receptor antagonist, or a beta blocker, and that often depends on the corresponding comorbidities. So to summarize, for most patient populations, a blood pressure target of less than 130 over 80 is very appropriate, but we really must individualize our blood pressure management and our targets. Blood pressure intensification in the elderly may be beneficial, but with regards to cardiovascular outcomes, cognitive impairment, and all-cause mortality. But we must be very careful for those patients who are very frail and who need multiple medications. Blood pressure intensification in chronic kidney disease may also be beneficial in benefiting cardiovascular outcomes and all-cause mortality. On the other hand, it may increase the risk of acute kidney injury if they previously have not had CKD. So for me, the first-line agents still remain the diuretics, the ACE inhibitors and ARBs and calcium channel blockers, and SGLT2 inhibitors should be considered for additional benefit to reduce cardiovascular outcomes and delay progression of chronic kidney disease while we're concurrently lowering blood pressure. And thank you very much for your attention. And thank you so much, Professor Hong, for your translation